So in every case, we should be as effective as possible. It is all treatments should be as effective as possible, as less toxic as possible, as simple as possible, as short as possible, and as economic as possible. So during from the morning to night, we do the pushing the target forward and pushing the OARs backward, so that we get good target coverage and good OAR constraints. So if you see the diagnosis of esophageal cancer, mostly it looks malignant, and most of the mid-esophagus cancers are mid-esophagus is the squamous cell, and distal esophagus is the adenocarcinoma. So always search for gather any small piece of important information like a physical examination and endoscopic examination, endoscopic ultrasound, CT, PET, evaluate operability and resectability with tumor board discussion, consider aggressive multimodal approach, optimize right radiotherapy target volume to avoid treatment pore, monitor and adapt to change during radiation course. So if you see any change in the contour or any wrong in the contour, it will give the total systematic error. So target delineation is very important, and you have to target delineate properly so that it will have a good result. So if you see the if you go from the incisor teeth to the G junction, the upper esophageal sphincter is at 15 centimeter, sternal notch is 20 centimeter, azygous vein 25 centimeter, inferior pulmonary vein is 30 centimeter, gastroesophageal junction is 40 centimeter. So 15 to 20 centimeter is the cervical esophagus between upper esophageal sphincter to sternal notch, 20 centimeter to 25 centimeter upper thoracic, 25 to 30 middle thoracic, 30 to 40 is the lower thoracic. So if you like the 5 incremental, and lower esophagus is 10 incremental centimeter. So if you these are the various definitions in the X, there is a location is unknown. Upper esophagus to the lower border of azygous vein, middle is the lower border of azygous vein, the lower border of inferior pulmonary vein, and lower esophagus is the lower border of inferior pulmonary vein to the gastroesophageal junction. So these are the AJCC location criteria. So you have to if you are going for the staging purpose, you have to see the azygous vein. You have to identify the azygous vein, inferior pulmonary vein, and gastroesophageal junction. These 3 things you have to find out. So these are the esophageal group of lymph nodes, mostly a mediastinal group of lymph nodes, apart from the supraclavicular lymph nodes and perigastric and the celiac group of lymph nodes, mostly it metastasis. So lymph node invasion always depends upon the depth of invasion, number of lymph nodes, positive metastasis, poor tumor differentiation, longer tumor length after the esophagectomy. And if you see, the upper esophagus mostly goes to the supraclavicular and upper paratracheal group of lymph nodes, though it is a very chance to go to the esophageal gastroesophageal group of lymph nodes. And slowly, if you go to the mid esophagus, so mostly the middle part, like mediastinal group of lymph nodes, will involve more, and G junction, celiac node, perigastric, gastrohepatic node will increase, and in the lower esophagus, supraclavicular chances are less, and gastroesophageal, meaning perigastric nodes or gastrohepatic nodes chances are increasing. So as you know, the staging mostly 1 to 2 lymph nodes N1, 3 to 6 is the N2, and 7 or more is the N3. So if you want to nomogram the predictive of pathologic lymph node involvement prior to the treatment, it is a clinical calculator. You can find out this MD Anderson site. You can see what is your endoscopic length, what is the clinical end stage, what is the clinical T stage. You will be able to know how many numbers of lymph nodes, pathological lymph nodes involvement you can predict. So cervical esophagus include supraclavicular and possible radiation target volumes should be cervical and supraclavicular. Proximal 1/3 supraclavicular and paraesophageal, middle third paraesophageal, distal third is the paraesophageal, lesser curvature and celiac axis group of lymph nodes. Target volumes are not straightforward, are straightforward. No, the target volume delineation is not straightforward. So because the curvatures are there are many anterior curvatures and lateral curvatures. The curvature it follows anterior posterior curve vertebral column through neck and thorax. So there is an anterior curvature. It follows the curvature of the vertebral column. Lateral curvature is a midline in front of prevertebral fossa in the upper part, then inclines straight to left, then enters thoracic inlet, then again T5 at midline, T7 slightly again it goes left, and then passes in front of thoracic aorta. So there are many lateral curvatures and anterior posterior curvatures are there. So it is not straightforward. So when you are giving the CTB, so it is not like that will go to direct it will go if you control the sometimes GTB will give CTB will give upper and lower, it will go out of the esophagus area. So because of the curvature, we have to keep in mind. So always keeping the target is very important. Defining the target is very important. If you take extra target, you will have more side effects, and if you take the less target, is high chance of recurrence. So always you have to we are fumbling where is the target. So defining the target is very important. So for central and mediastinal tumor nodes, the London Cancer Guidelines, you have to use mediastinal window setting and 0.5 centimeter along the direction for CTB and for the mediastinal group of lymph nodes. So to adjust the windows is very important. You go to your imaging window, drag your mouse in the horizontally, the width will change, and drag your mouse vertically, the level will change. That is very important to understand. So if you see what is level and width, you see this is the image, the two images are there, left and right. Left is the brightness, that is called a level, window level, and this is the called window contrast width. So contrast or window width. So if you change drag your mouse vertically, so window level will change, and drag your mouse horizontally, your window width will change. If you go diagonally, so you have to adjust the window. So this is the various mediastinal window, long window, subfish window, liver window. They are the various width and level, so that you can go ahead for the contouring. So which image is very standard for this thing? Standard images is the CT. Complementary information we can get by PET scan. And PET scan when you are a suspicious condition. See, there is a suspicious node here. We are not able to define. Some bodies you cannot give contrast because of the kidney issues, and some other things you can have a suspicious node. So it is when it is unclear, think of nuclear. Means you have to take the help of the nuclear medicine. So if there is a suspicious node, you are not able to find. So you can see the growth, the medicinal group of lymph nodes you will find easy to see in the PET. If there is a paravertebral node here, you can see this paravertebral node is suspicious and it is there. And sometimes PET is also helpful to increase your target volume if there is a suspicious node. So you can see in the left and right, because of the PET CT, there is a small node defined. So you have to increase your PET target field borders. So hence, it helps in the screening of the metastasis detected by CT alone, or tumor node metastasis staging and radiotherapy planning. PET CT is helpful. So if there is upstaging, prevents geographical miss, and your treatment may be curative to palliative. If you do the PET and if you are downstaging T stage, so prevent extra dose to the normal tissue, may changes the treatment from palliative to curative. Dose escalation is possible. Same thing happens in upstaging, downstaging, nodal stage, M stage, TNM stage. You have to see. So when things are suspicious, PET CT is auspicious. So very good line. So when you are thinking suspicious, go for a PET CT. So that will be helpful for you to define the disease, because CT scan mostly in the bird's eye view, and PET scan is the eagle's eye view, so we can see easily and define easily and have some confirmation in your mind to go for the treatment. So radiotherapy usually mostly useful for the definitive when there is a you have to go mostly cervical, inoperable, other esophageal cancers. Either you can go for external RT or concurrent CT-RT. Post-operative adjuvant setting, you have to rare but difficult to tolerate. Palliative RT, you can go for the dysphagia 35 to 35 degree, and you can go for the brachytherapy also. So ITB, it really exists. Current practice RT uses ICRU definition for target volume, GTV, CTV, PTV. But ITB, there is a small movement in the esophagus also. If you incorporate the ITB, it is a more difficult procedure. We are not practicing the ITB into the concept, practicing daily to daily life, but we have to control the GTV, CTV, PTV. So what NCCN guidelines says? The NCCN guidelines says you give 3 to 4 centimeter expansion superiorly and inferiorly, and 1 centimeter radial expansion is incorporated to the GTV, CTV, GTV to CTV, and 0.5 centimeter is the 0.5 to 1 centimeter your expansion. About depends upon you are using IGIT or ITV plan or something. So this is the basic line. So typical radiation field for the 2D field is, you know, usually radiation field this thing, it is a T-shaped for including supraclavicular area. So this is for the typical mid-esophagus growth, and this is for the G junction growth where you have to spare the cardiac APPA, and there is include the celiac access node. This is usually L-shaped. So in the upper part, it is a T-shape, then I-shape, then L-shape. So you can remember TIL. So this is the T-shape, I-shape, and L-shape. So this is mostly L-shape, as I told, for the lower esophagus, as I showed. I will come later. So organ sector is mostly spinal cord, lung, heart, liver, kidney, and spinal cord. Kidney usually comes when you use lower esophagus G junction growths. So lung and trachea can lead to coughing or shortness of breath. If the esophagus cancer is invading the trachea, there is a long-term risk related to scarring. So you have to see whether the trachea should be included or not. I will come. So mostly pre-operative setting, you are going for the cross protocol 41.4 gray in 23 flexion, and some cases you can go for the 54 gray, 52.4 gray. Post-operative setting 40 to 50 gray. Definitive setting 50 to 50.4 gray in adenocarcinomas, and there is many meta-analysis they showed that if your squamous cell carcinoma is there, cervical esophagus is there, you can go for the 60 to 60 gray. So dose constraint is a common practice. You can see the lungs, heart, pericardium, kidney, spinal cord. These are the various dose constraints for the things. So these are the dose constraints for the various. So when you are going for the IMRT VMAT plan, please keep it to that makes dose at point. So these are the various volume 30, V20, V30, V10, V5. This should be keeping in remember, because when you are planning for the VMAT and IMAT techniques, your low dose volume will increase. So please keep it less than acceptable variation V5. I usually follow V20, V10, and V5. So it should be V20 should be less than 30, and V10 just be 50, and B5 less than 55. So these things you should keep in mind. Hard dose is a lower esophagus and mid esophagus, you will get the hard dose. Maximum dose should be 0.3 cc, 50 to 54 gray. Mean dose should be less than 30 to 34 gray, and P40 should be less than 50 gray, 50%. Kidneys, normal dose, this maximum dose of B20 less than 30%. Or less than you can keep that. These are spinal cord, liver, as you know regularly, and you can follow the RTOG 1010 protocol for your daily convenience. So there are many protocols. If you are going for the CTV, GTV, PTV protocol for the esophagus, there are CAL-GB 808-803 protocol, RTOG 1010, Cross, OAK1, Abraham guideline, and MD Anderson. There are many guidelines are there. So what is the advice from RTOG? So RTOG 1010, it is a new adjuvant setting for the gastroesophageal junction and settings. So these are the mostly they give 50.4 gray plus paclicarbo, and these are the RTOG 1010 protocol. So in according to the RTOG 1010 protocol, so you have to do the GTV, give 4 centimeter super inferior, 1 to 1.57 radial margin to include the paraesophageal and celiac lymph node axis, and PTV for the 0.5 centimeter to 1 centimeter, and you have to go for the 50.4 grade in 28 fraction. So suppose this is the pet disease, this is the GTV. You have to do 4 centimeter above and down. So this is your CTV, and you give 1 centimeter, 4 centimeter above and down, and 1.5 centimeter radial, 1 centimeter radially, and PTV 1 centimeter. This will be your the PTV. And this is the radiation dose beyond the spillage. Cross trial, again, mostly cross trial we do IMRT, VMAT planning, but usually cross trial is a 3D protocol. So in cross trial, it is a pre-op setting, 5 weeks of chemo plus RT, surgery versus surgery alone. Paclitaxel, carboplatin we have to give weekly. RT dose is 41.4 gram, 23 fraction, surgery within 6 weeks after completion of chemo RT. So in cross protocol chemo, they were given 4.14 gray followed by surgery. So according to the target volume, CTV is again 4 centimeter expansion above and down, 1 to 1.5 centimeter radially. GTV node, they have taken 1 to 1.5 centimeter in all directions. Celiac node should be covered in G junction. PTV co-expansion should be 0.5 to 1 centimeter. And you can go for the post PTV around 50.4 gray if GTV primary and GTV node with an expansion of 0.5 to 1 centimeter. So this is the GTV, this is the CTV, cropped from the anatomic structure. What are the anatomic structure? Aorta, vertebra, trachea, lungs, and liver. I will come how to do these croppings. Target volume is GTV, red, then CTV, then PTV. Radical setting, you can go for the Abraham article published in 2015. This is the most used article in the radical settings. So this is the CAL-GB 80803 settings. In treatment planning, what should be the treatment planning? Whether you have to give IV or esophageal contrast may be used to aid as a target localization. You can put arms above, do a proper immobilization, consider 4DCT. Usually, we put the hands up position above the head, so that it is a, if you are planning the arcs and all things, it is easy to consider planning. So this is the best position for the esophageal planning. I usually what I do, so to stabilize the head, so there is head rotation, hand rotation, I put a 4-clamp head and neck or head and neck or fit in this position, that will be comfortable to the patient. So this is the best position, we can go ahead. So this is the another, so you can see the contouring, we can see this is the node, here is the node, this is the growth here, and this is the growth here, you can see. So how to delineate the GTV? Gather any small parts of information from clinical physical examination, endoscopic ultrasound, endoscopic guidance, CT, PET. CTV should follow geometric expansion. Is it really? No. CTV should be oriented along the esophageal instead of being a simple geometric expansion, because as I told before, the esophagus is going left, right, if anterior posterior along the esophagus. Proximal CTV margin 3 to 4 centimeter margin above the GTV, 1 centimeter or in 1 centimeter above the gross limb periphyseal node. Pathologic analysis of microscopic extension, microscopic resector tumor specimen indicate that proximal and distal mucosal 3 centimeter may be sufficient for the majority of the cases to see the submucosal spread. So it is pathological, it is seen that 3 centimeter margin above and below the GTV is sufficient to take care of the submucosal spread. So proximal CTV in a very proximal tumors. For every proximal tumors, the upper part should not extend above the level of the cricoid cartilage unless there is a cross stitch. Suppose you are planning for a cervical esophagus, upper esophagus, if you are given 3 to 4 centimeter margin, and if it is going above the cricoid cartilage, no need to take above the cricoid cartilage. Distal margin, it should be oriented according to the esophageal curvature, and you 3 to 4 centimeter margin. Radial margin, you should be 1 centimeter. Usually nodes are less mobile. You can plan for the 1 centimeter radial margin usually to given to enclose the lymphatic structure. But distal margin for G junction tumors. So sometimes G junction tumors, usually if you give 4 centimeter margin, it will totally cover the stomach, and that is the problem. So it is a very tricky position. In this one, at least 2 centimeter margin along clinically uninvolved gastric nostril is recommended. A 4 centimeter or gastric greater margin may be appropriate for with insignificant gastric extension like Stewart 3 lesions, lesions extending more than 5 cm to the stomach. So if you are a Stewart type of 3, where the epicenter is in the below G 2 cm below G junction, better go ahead with these things. So this is the type 1, type 2, type 3. Mostly esophageal is a Stewart 1. Stewart 2 mostly G with the G junction, and Stewart 3 is mostly stomach origin. So modify the steep. How to modify your CTV? When you are given 1 centimeter, 1.5 centimeter, please prefer 1 centimeter rather than 1 centimeter, 1.5. So how to crop from the heart, liver, vertebral body, descending aorta, and lungs? So it is recommended that CTV expansion may be limited to 0.5 cm to the cardiac tissues, including the pericardium. So you remember, 0.5 centimeter, you have to go inside the cardiac. If you given 1 centimeter margin, your 0.7 centimeter, it is going towards the heart. Don't crop abruptly from the heart. At least 0.5 centimeter into the cardiac tissue, 0.5 centimeter into the lung tissue, it should be taken. Vertebra, if unless there is a prevertebral fossa is involved or something, it is a prevertebral extension, you can crop from the 0.5 centimeter vertebra, but still I prefer 0.2 to 3 mm towards the vertebra. I prefer. CTV expansion can be limited to 0.5 into uninvolved liver. Even your CTV is coming to the liver, take the 0.5 centimeter of liver, not more than that. Excluding liver and heart from the CTV entirely is reasonable if robust motion management techniques are available. Celiac node contouring also very important. When your celiac node vessels are there, you have to contour. Usually it is located in a T12, and around the celiac node 0.5 to 1 centimeter margin to the aorta, it gives your the vertebral celiac node prophylactic marking. The kidney should be excluded from your CTV. So this is your celiac vessel, aorta, and you give 1 to 1.5 centimeter margin along the extension. So it will include your celiac node. Splenic node, do you treat? Yes, no, no, yes, it is not considered a regional node, but if there is a Stewart type of Stewart 3, splenic ileum greater curvature can be at the discretion of the treating physician. So it is not a strict indication, but if there is lower esophagus Stewart type 3 or 2, you can include. Nodal volume in G junction. So in the upper abdomen between the level of the G junction and the celiac, it was recommended that paraortic gastrohepatic ligament and included in the CTV. I will show you. So this is the liver, this is the stomach. This area is called the gastrohepatic group of area. So most of the esophageal lower esophageal G junctions nodes, you have to contour the this junctional area nodes. This area. This is called gastrohepatic area. That is nodes. That is you have taken as a prophylactic. You have to contour. Handling the supraclavicle node further above the level of the carina, it was recommended bilateral supraclavicular nodes should be included. The recommended borders for the supraclavicular nodes are level 4 nodes in the head neck cancer, which cranial border at the level of cricoid. The recommended borders for the supraclavicular node, the cranial border should be, if the 3 things you have to remember here. If your growth is above carina, then include supraclavicular node. Second point, even if you give supraclavicular, your cranial border should be the level of cricoid. And the cranial body is the level of cricoid cartilage, and the anterior, posterior, and lateral borders correspond to the borders of the sternocleidomastoid. As you contour the supraclavicular areas in the head and neck, or if breast cases, you can handling the supraclavicular very nice. But remember 2-3 things. If your growth is above carina, include the supraclavicular node, and your margin should not go beyond the cranial border of the cricoid. So this is the breast contouring guideline. You can see the supraclavicular, cranial is the caudal to precardial, caudal is the junction of brachiocephalic and axillary veins, or caudal is a clavicular head, anterior sternocleidomastoid, posterior anterior aspect of scalene, cranial the lateral edge of sternocleidomastoid, caudal the junction of first rib and clavicle, exclude the thyroid and trachea. So delineate the very simple way, delineate the space between the sternocleidomastoid and posterior scalene muscles around the vessels, all fat spaces, anterior sternocleidomastoid, posterior sternocleidomastoid borders, exclude trachea, esophagus and thyroid from the supraclavicular area. Handling mediastinal nodes. So distal tumors in which CT extends superior to the mediastinum only to order respect of 3.4 centimeter margin of gross tumor. Panel did not consistently mandatorily include the superior mediastinal node station electrically. Other than what is the radio 1 centimeter radial expansion is coming, you can take it. Above the eye gauze, the anterior border of the CT can be extended toward the sternum and clavicular to encompass the prevascular nodes. Above the aortic arch, if your tumor is there, CTV can be extended toward the sternum and clavicular to encompass the prevascular nodes. So this is the sternum and clavicular nodes to include the prevascular group of lymph nodes. The pen did not consider it mandatory to deliver it into the supramaxillary node station, other than would be encompassed 1 centimeter radial. So 1 centimeter radial expansion you give, and it is not mandatory to include all the nodes. And if you are above the aortic arch, the anterior border should include the if growth is above the aortic arch, include the prevascular group of lymph nodes by extending your CT. Handling enlarged nodes, usually nodes are moved very slowly, not much movement. I usually prefer 0.5 centimeter rather than 1 centimeter in all directions. Handling the trachea, this is very tricky. If above the carina and below the carina, so the CTV will therefore typically encompass the entire trachea, extend radially in order to encompass the lower and upper paratracheal upper nodal stem, which correspond to the level 2 endoderm. Above the level of the thoracic inlet, the trachea should be excluded from the CTV, except for the 1 centimeter radial vent from the normal ICP. So if you are given margin to your esophageal growth, if above carina, you can include the nodes. Your trachea should be included in your field. But above the thoracic inlet, you should exclude the trachea. The trachea should be excluded from the CTV, except 1 centimeter radial margin to the normal esophagus requires it. So when you are giving 1 centimeter margin, take that one only. But no need to include the whole trachea above the thoracic inlet, but include the trachea above the carina. So these are the various paratracheal nodes. So this is how you have to include the above carina. You have to include the paraesophageal group. Whole trachea should be in your field. PTV margin, if you are should be 0.5 to 1 centimeter in all direction. Respiratory motion should be is observed to be in excess of 1 centimeter. The panel additionally recommend the use of techniques such as respiratory getting abdominal things. I don't prefer in the esophagus, but if you are taking, you can use a less margin, but at least 0.5 to 1 centimeter margin you should give. Stomach planning, again, it is a very important thing. Location of perigastric nodes, those to normal structures is very important. So to reproduce the gastric positioning and at least 2 to 3 hour fasting or 4 hours fasting, you should do. And what is the CT simulation picture should be there, you should take. Otherwise, unlessly, usually sometimes your PTV or stomach will count in the PTV, sometimes it out. So empty stomach, you have to maintain a single pace. So 4 hour fasting, give 30 ml of water. It is easily, it is act as a negative contrast, and it will be easy to identify. So it is better to give treat in empty stomach. In special situations, you see, this is the thing what you have to do. If your patient is, you put barium swallow, today it is there, your CTV PTV, CTV will be there, big issue CTV. But when your tumor regresses again, it will come down. So in situations you put a Ryle's tube in large dilated esophagus. So you put a Ryle's tube or peg so that it will help you drain the something to help the drain the ballooning of the esophagus. Proximal esophagus, you have to include the supraclavicular node and peritracheal group of lymph nodes. Yeah, this is the how we contour. Distal esophagus, you have to see. You can see this is the gastrohepatic group of nodes, cilia group of lymph nodes. You can see G junction tumors. Again, it is a very tricky in G junction tumors. So you cannot take 4 centimeter like margin. So what you have to do? There are 3 CTVs. One is the CTV esophagus, CTV stomach. So this is the things we have to change. I will see. So this is called a superior CTV. So you draw the GTV. Then give 3 centimeter above the esophagus. Above, that is called superior CTV. That is called superior CTV. That is or esophageal CTV. Then you give 3 centimeter. You take the 3 centimeter of stomach. Your GTV, your 3 centimeter of stomach. Left, that is the CTV, CTV stomach. This is you have to take the CTV stomach 3 centimeter. Contour into the stomach 3 centimeter of G junction to the last slash of GTV, only include the stomach. So suppose you are the GTV here, you go from the up to down, 3 centimeter of stomach, normal stomach has to be contoured till the lower slash of GTV. No need. Then radial CTV. So you give 1 centimeter radial CTV along the all things. That is expand the GTV stomach within 1 centimeter radial to make the mild mid CTV. So you contour the stomach, you contour the GTV, you contour the this is the called radial CTV. Then inferior CTV, you have to another 2 centimeter from 2.5 centimeter from the GTV. You have to include expand the last layer GTV included 2.5 centimeter. So this will be 2 centimeter from the inferior CTV. So you have a superior CTV, stomach CTV, inferior CTV, and radial CTV. So 4 CTVs you have to contour and include. So this will be your total CTV: superior, inferior, stomach, and radial. So these 4 CTVs will be your CTV. Then PTV, you give 1.5 to 1 centimeter, and this area you can take extra margin. I feel better 1 centimeter for the lower esophagus rather than 0.7. So this is how it we contour, take the normal stomach. So grossly and guideline, you can see circumferential 1 centimeter, involved node 0.5 to 1 centimeter, CTV to PTV 0.5 centimeter, and below carina same as upper esophagus, same as upper esophagus, and peri-esophageal nodes, mediastinal, perigastric, and celiac nodes should be included. Post-obstetric is another important thing. Your histopathologically slides should be pathology, depth of invasion, number of nodes, number of location of nodal disease, presence of skip lesions, perineural invasion, type of surgery, everything you have to find out. So I can tell you, if there is a squamous cell carcinoma, R0 resection, either node positive or negative, no need of treatment of further treatment. Remember, this is very good. R0 surveillance. But if you are R1 or R2 dissection, then you can go for chemoradiation in post-op setting. But in adeno-CA, it is adenocarcinoma. If node positive, you give to chemoradiotherapy, it's a must. Beyond PT2, you have to give chemoradiation. If node negative, you can observe, but you can go for chemoradiation. But if there is node positive, R1 dissection, R2 dissection, you have to go for chemoradiotherapy according to NCCN guideline. Post-observation is squamous carcinoma target volume denomination. We can go for this target. So people are various people. They told you have to take left gastric group of lymph nodes, mediastinal lymph nodes, supraclavicular lymph nodes. So this is a variation. So it is your discretion what to take and what not to take. And target volumes is a bilateral supracave, mediastinal node, celiac trunk, tumor bed, R1, R2, circumferential reserve margin. Esophagus circumferential resection margin is very important. You have to remember. So how to decide? Extending surgical lymph node clearance, site of relapse after radical esophagectomy without preoperative chemotherapy and radiation, and stage and location of the primary lesion. These are the how to decide. exclusion. They conclude that it may be unnecessary to irradiate a left gastric area when the primary lesion is located in the upper end esophagus. Likewise, bilateral supraclavicle area is unnecessary to treat in case of middle and lower esophagus. So these are because this is a complexity area, arch of from the arch of aorta to esophagus complexity. So upper and middle thoracic esophageal commotion to the cervical difficult to complete. So because of the complexity, upper mediastinal lymph node dissection is difficult, and lower mediastinum and upper vertebral sites that can be exposed more easily. So you have to think the mediastinal group of lymph nodes to be treated. For upper and middle esophagus, various studies have reported that bilateral supraclav and superior mediastinum have the highest rates of recurrence, should be included within port of CT. Lower esophagus, paracardiac, left gastric, and or upward such as bilateral supraclav and super remains understudied. However, recurrence pattern for the lower third still obscure. Current conflict evidence does not rule out any area. So, but don't know if there is a lower esophagus, don't treat the supraclavicular and upper mediastinum group of lymph nodes. Handling the stoma, if cut margins are negative, no need to include the stoma. No need to treat the gastric pull-up. So suppose gastric pull-up is coming through the stomach, lungs, unnecessary, don't treat. Only you to target should be treat the tumor bed, clips, mediastinal nodes, only mediastinal to be include the nodes. You don't need treat the gastric pull-up. You no need to treat the stoma if it is a negative margin. I will highlight two things. Suppose if you are planning for the PTV, you are most of the people, if you go for the VMAT planning, round planning, it is called a round planning or full arc. If there is a full arc, it is we have seen the high chance of low dose volumes in the lung is 5% volume and everything is bad. So what you have to do, you may get some spikes in the lung, but low volume dose in the pneumonitis chances will be because your patient is going for the surgery after few days, few weeks. So this is called APP arc. This is called APP arc. You don't go full arc, so your constraints will be achieved better. Another thing is that radiation to the gastric fundus area increases the anastomotic leakage after esophagectomy. So if you are given support your plan for the cross trial, if your gastric fundus is increasing the area to those, so it may causes some leakage. So how to handle? So there is a called fundus, gastric fundus target delineation and dosing pattern. So unless your gastric fundus is involved, you contour your fundus around the just below the draw a line G junction to the lower part of G junction, a straight line, contour the around 2 to 3 centimeter of fundus in your coronal or sagittal section, and patient who did not experience post-operative anastomotic leakage after receiving main dose to the gastric fundus 11.8 areas within illo respectively. So usually the mean dose should be less than 11.8. They don't experience in the leakage. So a mean dose more than 30.4 gray associated leakage around 43% versus 15% respectively. Adjusted tumor location, clinical T stage, radiation method, mean radiation dose to the gastric fundus remains significantly independent with increased risk of leakage. So try to control the fundus, keep the dose minimum, don't underestimate your PTV. Brachytherapy, you can go for the ABS guideline, American Brachytherapy Society guideline. So if your good candidates, if tumor is less than 10 centimeter, confined to esophageal wall, thoracic location, no regional lymph node. Poor candidates, extraesophageal, more than 10 centimeter, regional lymphadenopathy involving the G junction. Contraindications, don't go if there is a fistula, don't go cervical esophagus, stenosis which cannot be bypassed. So these are the mostly, if you go 42, suppose you can, this is a very good thing. If you have suppose you have a plan for a cross protocol, you given a 41.4 gray to 50 gray. After radiation, the surgeon told that I cannot do surgery because my patient may not feed, some gross residual is there. If surgery denied from something, so you can plan brachytherapy at that point. No, what you will plan? You give 5 gray per fraction start the radiation after 2 to 3 completion of external beam, and 5 gray per fraction, 2 fractions it will give adequate dose to the mid-esophagus. So this is the best thing we can do, that when the surgeon denies I cannot do the surgery after the protocol. So this is the how your 4 centimeter growth, give margin 2 centimeter upper and lower, and your treatment area should be 8 centimeters. So this is for the brachytherapy. Lymph node delineation, you can follow this guideline, and many atlases available from the one. There are 14 group of lymph nodes. You can see these are the lymph nodes. I don't want to go very early, very detail. This is a supraclav, upper 2 is the upper paratracheal, 4 is the lower paratracheal, 5 is the aortobronchial group of lymph nodes, 6 is the paratracheal group of para-aortic nodes, 7 is the subcarinal, 8 is the paraesophageal, 9 is the pulmonary group of lymph nodes, 10th to 14th is the hilar group of lymph nodes. So this is the supraocular paratracheal. This is the prevascular. 3 is the prevascular. This is the prevascular is the 3A. 3B is the prevertebral. Lower paratracheal is the 4 group of around aortic arch. This is a 4 group. Lower paratracheal above boundary is the upper border of aorta to lower border of aorta. This is the subaortic and para-aortic group of columnar 6. Paraesophageal is the 8th. 7th is the subcarinal group of lymph nodes. So this is the 3P is the prevertebral. 1 is the sternal nodes. This is the 3A prevascular. 3P is the prevertebral. This is the 4 is the lower paratracheal. 6 the para-aortic internal mammary, that is not included in this area. 6 is the para-aortic. Then 7 is the carinal, subcarinal group of lymph nodes. 10th, 14th, it is the hilar group of lymph nodes. This is the paravertebral group of lymph nodes. So this is the pulmonary ligament group of lymph nodes. So this is the, you can see the contouring of the fat spaces around the vessels without any lymph node enlargement. You can see the contouring, how to contour the lymph group of lymph nodes. So comments, follow the guideline, practice it, revive your own data, be a part of guideline, and that will help you day by day the practicing the target delineation. Thank you very much for patient hearing. If you have any questions, you can ask.
So good evening.
Hello.
Hello. So good evening. I had a little query. Sir, for the geometric expansion, when we are taking the superior and inferior CTV, as to what you explained, draw the normal esophagus and then give the final PTV margin. We need not give a radial margin to the superior and inferior extension. So radial margin needs to be given only to the gross volume. That is the question.
Radial margin, you have to give the radial margin to, so you just go to 3D expansion and paraesophageal group of lymph nodes you have to include. What I do, sometimes what I do, I do the GTV, give 1 centimeter radial margin, 3 centimeter superior margin, 3 to 4 centimeter superior margin, 3 to 4 centimeter inferior margin. So what you have to include the normal paraesophageal upper and lower, you have to follow the curvature.
Okay.
Along the curvature you have to do. If you given directly CTV, you have to edit, and at least 0.5 centimeter of lung, 0.5 centimeter heart, 0.5 centimeter liver, if it coming into your field, take it.
Okay. And sir, paraesophageal nodes, as far as they are concerned, we need not voluntarily take them through the lens. Like as per the definition, paraesophageal is a long area. What we need to take is just along whatever is coming in the PTV margin.
No prophylactic.
No prophylactic, no? Okay. And sir, are you doing adaptive or onboard imaging? What is your imaging protocol, sir?
I use CBCT. I usually, for thoracic and abdominal, I do daily CBCT.
Daily CBCT. What will be your red flag for the dose and plan achieved, sir? regarding for OAR constraints, what will be your red flag completely not acceptable for cord, heart, and lungs in a case of C esophagus?
So I keep my primary target is the GTV, CTV, PTV, and I keep the V20/30 lung.
Okay.
PL minus PTV, V10 less than 40, and V5 less than 55 or 60. Okay. And heart, at least because lower part and mid part, I have anyhow it comes. And when people think that, sir, heart dose is coming more, what I will do? See, esophagus is not, patient is not going to live for the 10 years.
Yes. Yes.
When your complication comes, that time patient will be not there. So yes. Don't much constrain. How much save the heart, lung actually.
Okay.
Because patient will go for the surgery and everything, but
so primary weightage, maybe lung, we shouldn't be compromising that much in order to achieve for the heart.
Yeah. Okay. So you can control the anterior-descending artery, that LAD, left. So you can give the constraints, but maybe it meaning over enthusiastic protection. But,
okay. Thank you, sir.
Any other questions? Hope you people enjoyed my talk. If you no questions, we will close the session.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you so much for sir for giving us the opportunity to host the session. Thank you. We hope to have you again on our platform very soon. Thank you so much, sir.
Thank you.
Thank you.